And my student number is 1487347, and this is my pre-hospital OSCE. I've been dispatched to a 22-year-old male complaining of shortness of breath. It is a very cold evening. My patient is conscious and alert. He's orientated to time and place. His vitals are as followed. His heart rate's 110, rest rate is 40, his BP is 100/70, temp is now 38.7, speed GR is 5.9, and his CAT refill time is of 3 seconds. On arrival, we turned up to a cold and damp house. This patient lives alone. We did his primary survey with his ABCs and they are all intact. We can look at him now, and as I can see is that he's well perfused and not cyanosed. He does not appear to be diaphoretic. He is not in the tripod position. I can't see any nasal flaring or indrawing. We can't see any accessory muscle use, although he still does have an increased rest rate. I will now introduce myself to this patient and we can then gather any additional vital signs. Hi, I'm Jasmine. I'm a paramedic student. What is your name?
I'm Josh.
Okay, Josh, I can see that you're struggling to breathe. Can you please count to 10 for me?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
I can see that Josh here can count to 10. He's speaking full sentences, but although he's only counting to 4 and he has to take a breath in, this is showing that there's some sort of respiratory condition going on. We will further our assessment to try and see if we can downsize it to just one primary condition. I'm just going to ask you one more question. Do you have any respiratory conditions that we should know about? No. So learning that he doesn't have any respiratory conditions that we need to know about, we need to try and figure out what is going on. I will now inspect the patient's chest to see if he has any equal chest rise and fall or has any trauma. Have you been in any trauma recently? Okay. I'm just going to inspect the patient's chest to see if there's any equal chest rise and fall. Look, I can see that there's equal chest rise and fall bilaterally there, so that can rule out any trauma to the patient's chest. I will now auscultate his chest to see or hear for any abnormal sounds. So I'm just going to bring this down there. Can I just get you the leg forward for me? I'm just going to listen to your back. Oh shit. Oh, I'm just going to have a listen to your throat as well. Keep breathing. Yeah, I tripped up. On auscultation, I could not hear any wheezes present, so that can rule out asthma causing this. I did not hear any stridor when auscultating in his throat region, but I could hear some basal crackles down below, so that can indicate some chest infection or pneumonia going on. For our secondary, I can see that the patient here is grimacing and kind of holding his abdomen, so I'm just going to do a quick abdominal assessment. Can you please show me, are you experiencing abdominal pain at the moment?
Yeah.
I will now use a format which is OPQRST acronym to be able to get a little bit more info on this pain and see where it actually is. What time did this pain start in your tummy?
Don't know.
You don't know? Did it gradually come on? Or has
It's just gotten worse.
just gotten worse throughout?
Yeah.
Out of 10, so 0 being no pain and 10 being the worst pain possible, where would you rate your pain on this?
7.
About a 7 out of 10, so it's quite severe.
Yeah.
Okay. So is the pain radiating anywhere?
It sort of goes across,
Yeah.
but it feels like it starts on this side and goes across.
Any nausea and vomiting with this?
A little bit of nausea.
Just the nausea, nothing else?
No.
You haven't vomited?
No.
What's your bowel motions like?
They're pretty normal. I
And
think.
urine output?
It's pretty normal as well.
Pretty normal as well? Okay. So I can tell, the patient's said to me that his pain's radiating from his right hand side to about the front of his tummy, but it's more dominant in his right upper quadrant. We will now inspect the abdo, look for any rashes or discoloration, and we'll also palpate his abdo to see where the pain actually is, and we'll use the Murphy sign and we'll use a McBurney sign as well. I have exposed the patient's abdomen, so now I can actually look at his abdomen. I can't see any rashes or pura, so that rules out any signs or discoloration. I will now palpate his abdomen to find out where exactly the pain is. The first one I will use is the Murphy sign, which is I just palpate up and push under his rib cage. This is a sign. Any pain there when I'm breathing? Can you please take a deep inhalation? Any pain? No. So that rules out if there's any liver troubles involved. Another one I'm going to do is the McBurney sign, which I'll just put a pressure point about where his appendix is and press in and take away.
Oh.
We can see here that there is some rebound tenderness, which could indicate any appendicitis going on. That can cause either an acute or chronic respiratory distress in some patients, is your asthma, your COPD, your CPO, anaphylaxis, and even sepsis. I was able to grab enough brief history from this patient to rule out that he was not an asthmatic, as he did not suffer from any asthma. And then I was kind of trying to put into a abdominal assessment, which also helped that I could see there was no skin involvement, as he had no rashes or pura, to be able to determine that it wasn't anaphylaxis actually causing this type of respiratory distress. On the auscultation, because it's so important when you're dealing with someone who is short of breath, that you're able to come up with differentials, because you can either hear different lung sounds or abnormal sounds. The lung sounds that I heard when assessing this patient were fine crackles at the lower lobes of his lungs. So this kind of, for me, ruled in that he could either be suffering with a chest infection, CPO, or even pneumonia, as these conditions do rule in the crackles. With his vital signs, with his being a bit tacky at 110, his BP was a bit hypertensive at about 100/70. He was tachypneic at about 40 rest rates, and very febrile at 38.7. These, for me, were kind of showing signs of shock, and I was kind of getting into the more sepsis because of the increased rest rate, the febrile temp of 38.7, and the hypotension and cap refill time of being 3. Signs were showing some similar concerns for me of him actually being septic, but in the septic patient I need to figure out where the signs of infection are coming from. Yes, we heard crackles in the lungs, but I kind of wanted to rule out any gastrointestinal, so that's why I decided to do a abdominal assessment on this patient, also because he was grimacing and actually holding his abdomen, so it kind of showed signs of concern. As I proceeded to question him more and have a better look at the patient, he did actually open up and say that he had abdominal pain, and I was able to grab in more information, and when I palpated his abdomen, that he was actually experiencing appendicitis, and I found out this by using the McBurney's method of palpation, where you push in and you push into where his appendix is and you let go quite quickly, and that kind of shows rebound tenderness. And with this I thought he's experiencing signs of shock because maybe his appendix has ruptured, or just because of the appendicitis. If this on the road, I would proceed to call an R51 for backup, which is a paramedic, and this would just be for pain relief, as he was experiencing quite severe pain, being 7 to 8 out of 10. Maybe even a fluid challenge of the sepsis, and depending on how far from hospital and where we actually are located, maybe even try for some ABs, some antibiotics. With all the patient's condition and all his vital signs into one, I decided that this patient was actually status 2 and that he actually needed to be at hospital, which would be the best possible outcome for him. So with this being said, en route I would make an R40, which is a call to hospital, just to let them know the patient's condition and how he's reacting with the treatment that we have provided to him. And we would continue on doing this and getting him there safely, just to make sure that he gets the best possible outcome when he is in hospital.